Hello, everyone. Thank you for coming. Welcome to NAHDO's 40th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsors. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find more information about them and find game tokens. Game tokens are key words or phrases used in the token hunt game for a chance to win prizes in the daily drawings. Now, let me turn the stage over to Charles Hawley, NAHDO's Director of Projects. Charles, the stage is yours.
Hi, everyone. It's a pleasure to be here with you, and thank you all for joining us. Very excited to get the conference kicked off and to have you all here for NAHDO at 40. So let me just start off this session. How to use data to unpack hospital cost and efficiency was organized by KeriAnn, LaSpina, and Julie Sonier. Today's moderator will be KeriAnn, LaSpina, and the session is sponsored by Mathematica. We'd like to turn the time over to Julie Sonier from Mathematica to introduce today's session.
Hello and welcome to this session on how to use data to unpack hospital costs and efficiency. My name is Julie Sonier, and I'm a senior fellow in Mathematica's state and local division. For more than 25 years, I've been working to help states collect and use data to improve healthcare cost, quality, and access. Mathematica is proud to partner with NAHDO and to be part of this community that advances the collection and use of health data. As a mission-driven organization, Mathematica works to improve public well-being by using data and evidence to drive decisions that will make healthcare more affordable, accessible, and equitable. We love this work, and we especially love collaborating with our clients and partners, many of whom are attending this conference. We're delighted to partner with NAHDO to host this session today. The 3 presentations you'll hear offer practical, data-driven approaches to the challenge of addressing high and rising spending on hospital care, which is a priority issue for many states. Each presentation tackles the issue from a different perspective with the goal of arming you with tools and insights that you can take away and use in your own work. Before we begin, I want to thank Norm Thurston and Charles Hawley at NAHDO for their leadership in making this conference possible, and thank all of you for joining. We hope these presentations spark new ideas, collaborations, and insights. We look forward to your questions and insights following the presentations.
Great. Thank you, Julie. And let me go ahead and bring KeriAnn LaSpina on stage to moderate today's sessions and take us through the presentations. Hi, KeriAnn. You have
Hi,
the stage.
Charles. Thank you, and thanks to you and Norm for organizing this. And good afternoon to everybody. I'm so pleased to be moderating this very important session about hospital costs. I know this is an issue that is near and dear to many states and one that we spend a lot of time on at Mathematica. So we have 3 wonderful presenters today. First, we'll hear from Asmita Ghimire from Civic about hospital price transparency data. Then we will hear from Sarah Kinsler from Baillit Health to talk to us about hospital audited financial statements. And finally, we will hear from Alicia Duran and Alyssa Evans. Alicia's from the Massachusetts Health Policy Commission, and Alyssa is my colleague at Mathematica, and they will talk to us about a really cool market basket approach to measuring hospital prices. So with that, we'll turn to our first presenter. Take it away, Asmita.
My name is Asmita Ghimire, and I'm a healthcare data analyst at the Center for Improving Value in Healthcare, or CIVIC. Today, I will be presenting on transforming raw hospital pricing data into actionable insights, a project that supports better healthcare decision-making through data transparency. All right, before diving into the data, let me briefly introduce CIVIC. We are a nonprofit independent organization that provides data, resources, and services to support healthcare improvement across Colorado. Our vision is that everyone has access to affordable, equitable, and high quality care. What is in the Colorado All-Payer Claims Database? The COAPCD includes medical, pharmacy, and dental claims data covering over 70% of Colorado's insured population from 2013 to 2025. It contains over 1 billion claims from 33 commercial insurers, Medicaid, and Medicare. Our database is updated on a monthly basis. The exclusions are ERISA-covered self-insured plans, TRICARE, Indian Health Services, and the uninsured. Now, let's shift to hospital price transparency, the focus of this project. As many of you know, the US healthcare system is complex and fragmented. Care delivery and pricing involve multiple payers, including insurance companies, government programs, and the patient themselves. This complexity makes it difficult for individuals to understand the true cost of care. In fact, many patients don't know how much they will be charged until after they receive the bill. So, what is hospital price transparency and why it matters? In 2021, the Centers for Medicare and Medicaid Services implemented the Hospital Price Transparency Rule, requiring hospitals to publicly disclose prices for medical services they offer. This matters because it helps patients make informed decisions. It enables price comparison across hospitals. It promotes competition, potentially lowering cost. And finally, it increases accountability in pricing. Despite the policy, hospital pricing data is often difficult to navigate. Our Hospital Price Transparency Project aims to collect, clean, and standardize pricing files from 85 hospitals across Colorado. How we do this? We take machine-readable files from hospitals' website. We clean them and we load them into a centralized database to enable accurate cross-hospital comparison. This work is done in 4 key phases. Phase 1, initial file download and review. Phase 2, deep data cleaning and analysis. Phase 3, reporting database development. And the last phase is final or quality check phase. Let's dive into the phases now. In the first phase, we download the hospital files, we conduct the initial review, and we convert files formats as needed. And then we finally organize files in the central location for further analysis. Phase 2, this is the most intensive phase. We use many softwares like Excel, SAS, and R to clean and process the data. This involves identifying non-standard codes or formatting issues, restructuring rows when multiple procedure codes appear on the same line, aligning modifiers and removing invalid or outlier values, pivoting from wider to longer format as needed, flagging missing or incomplete price information, splitting large JSON or CSV files for easier handling, and finally, adding hospital-level metadata and documenting the process along the way. By the end of this phase, all files are cleaned, standardized, and ready for reporting. Phase 3, the clean data is integrated into a centralized reporting database. We also add row numbers to help identify and reference specific entries. This database now supports cross-hospital comparison, pair-specific pricing analysis, and we can also query the data using CPT or MSTRZ codes. And now the final and the last phase is quality check or QC. This is the critical step because we verify data accuracy, data completeness, and formatting consistency in this phase. The QC also ensures that everything is reliable and ready for use in reporting and analysis. What are the findings and key challenges that we came across? We encounter several challenges in working with hospital pricing data. Files are often large, so they are hard to load and process. Hospital interpret CMS rule differently, so file formats vary across hospitals. Many files have missing or blank values. And then some hospitals fail to meet CMS requirement or post unusable files. These issues limit the usability and impact of price transparency. Despite challenges, price transparency has positive implications for many stakeholders from patients to policymakers. Patients can compare prices and make informed decisions. Hospitals gain trust by being transparent. Employers get greater insights into negotiated rates, and policymakers can use the data to promote accountability and control healthcare costs. But of course, the full benefit depends on clean, usable, and accessible data. And lastly, some of our recommendations in conclusion. Standardizing formatting across all hospitals ensures data consistency, making it easier to compare prices statewide. Developing user-friendly dashboards for easier access, and then encouraging third-party tools that aggregate and simplify the data. This promotes innovations and helps transform raw data into actionable insights. That being said, hospital price transparency is a powerful step towards a more accountable, affordable healthcare system, but only if we make the data usable, comparable, and accessible to all stakeholders. Thank you so much for listening to me today. If you have any questions about the project or anything in general, feel free to reach out to me at the email address on the screen. Thank you. Bye-bye.
Thank you so much, Asmita. That was really interesting. I think we got started a little bit early, so I just want to give people an opportunity to ask some questions if they missed any of your presentation. And just a quick recap, Asmita talked about downloading hospital price transparency files and then kind of standardizing and cleaning them and ways that we can use them. So I want to also direct everybody's attention to a poll about how states might be able to use price transparency data. So far, it seems like 2/3 of respondents are thinking interactive consumer-facing price tools would be valuable, and 1/3 are looking to compare hospitals. So I'll open it up now for people to ask Asmita questions. Well, I have some questions, Asmita, while people are kind of pondering. I was wondering about whether the downloads are free and kind of the cadence of how often you have to download them.
Yeah, that's a great question, KeriAnn. So yeah, the hospital price transparency files, they are free to download. You can visit each hospital's website. They are usually located under a section called price transparency or charge master, and you can download files directly from there. However, one thing to keep in mind when downloading those files are some files can be very large, right? So often thousands of megabytes. So when downloading file, the file may appear cut off, especially if you open files in Excel or CSV, because there is a limit how many rows those software can hold. So we recommend opening them with the tools like R or Python or any other database program rather than just Microsoft Excel. And then about how often we download those files. So we download those files on our regular schedule. So 2 times a year, we internally call them like fall download or spring download, depending on when we download those files. But the CMS required hospitals to update their files at least annually. So that's the requirement. Hospitals are required to update their files.
Great, thank you. And we do have some questions coming in the chat. Dagmar Velez asks, what was the most difficult part of combining all of the price transparency data?
There were quite a few challenges that we came across while combining those hospital files. So although there is a CMS requirement and guidelines how the hospitals are required to post their transparency files, but not all hospitals are compliant with that requirement. So there are so many different naming conventions across hospitals. So some hospitals name the same column headers as XYZ versus other hospital names that column is ABC. So we had to rename every single column, and there are even with that there are so many incorrect information or incomplete or missing information. We had to manually update those data in the files before we even combine the hospital's files together. So incomplete file data, missing data, different variation in naming conventions are some of the challenges we came across while combining those hospitals' files together.
That sounds somewhat painful, so I appreciate what you're doing there. We have another question from Monica Canizares, and I apologize if I'm butchering your names. She has a few questions. One was there any need to do payer plan name standardization, and could you speak to that process?
We did to some level. So, like you can imagine, each hospitals, they have their own naming convention they follow. So some hospital, maybe they named, for example, let's take an example of pair Blue Cross Blue Shield. So they may name that Blue Cross Blue Shield versus other hospital may just like, say BCBS. So, right. So we did some cleanup. So versus like some other hospitals may name their pair as Blue Cross Blue Shield, and there are some extra information attached to that pair name. So in that cases, we did some cleanup. If there is extra information, if there are some invalid text and things like that, but we did not manually do cleanup to match the name across hospitals. There are so our final database do have all different naming variation, let's say BCBS or Blue Cross Blue Shield, but we did do some cleanup, like removing incorrect information, removing extra information attached to that pair, removing the pair if there is if all the information on that column is null or blank. So we did those kind of cleanup, but not cleaning up to match the name of pairs across the hospital files.
Okay, that's good to know. And Monica's second question is a great question. How do you handle bundled charges, if differently from other types of charges?
So Monica, can you expand to that question? So what do you mean by bundled charges? And I'm not sure what that is referring to.
Monica, I can chime in here. I'm not sure how your audio is, but there's certain payment mechanisms sometimes where services will all be bundled together under one payment, especially in Medicaid. We see that. So sometimes you don't have a good sense of what a specific service costs because it's all kind of bundled together. Just wondering whether you see that in the data and how you handle it.
Yeah, so we I don't remember 100% if I saw those information in the file, but if there are certain charges that did not make sense, or that looks completely like some kind of outlier value, then we flag those for the client to review. That's the cleanup we did with those charges, or that's how we handle the bundle charges, I would say.
Okay. And then one more question from Richard Rains. Can you elaborate on standards for reporting?
So what was the last question, KeriAnn?
Can you elaborate on standards for reporting? I think Richard's asking about what the hospital's standards are for their files.
Yeah, so there is a CMS requirement that says what fields the hospitals are required to report. So under CMS requirement that was passed in 2021, hospitals are publicly required to post 5 different standard charges that are gross charge, that is the hospital's list price for any procedure or service they offer. The other one being discounted cash price, that's the price what a patient will pay if they are paying with cash or without any insurance. The other one is per specific negotiated charge. So that is the actual negotiated rate between the hospital and each insurer or health plan. And then lastly, there are de-identified minimum and maximum prices. Those are the lowest and the highest negotiated rate among all peers. So those 5 prices are required by CMS for the hospitals to publicly disclose in their price transparency file.
Great, thank you. That sounds like really rich data. We have some more polling results here. It looks like about 40% of respondents are saying comparing hospitals now would be most valuable, and then 37.5 are saying interactive consumer price consumer-facing price tools, and about 20% comparing payers. I think we have a couple minutes, Asmita, so I have one more question to kind of round us out here, which is if you can talk a little bit about, you take in this data, you process it, you clean it, and then kind of what are some use cases of how you use it?
Yeah, so this project, we, like you said, we take those raw data, we combine them, we clean this up and combine them and put them in one, big reporting database. That's what we call it, reporting database. So using that database, we can see, like for one procedure, how much like the cost is across different hospitals. So we can compare, like for one procedure, how much each hospital is charging, how much each payer or insurance it will cost for me. So you can see, like, you can check or compare prices across hospital, across different payer, things like that. Also, we can take this further. We can use this data, we can link this with APC, let's say APCD data, and we can see or compare the price variation between those 2 data sources. So another use case would be just, combining this data, linking this data with other different data sources and comparing price variation, disparity in payment, and things like that.
Cool. Thank you so much, Asmita. That was really informative. And I think we can head off to our second presenter, which is Sarah Kinsler from Baillit Health. So take it away, Sarah.
Good afternoon. My name is Sarah Kinsler, and I'm really glad to be joining you all today for this how-to session. I'll be talking about how to gather meaningful data from hospital financial reports with a focus on audited financial statements and how we can use that data to inform policymaking. So we're going to start out by talking about why analysts would seek to understand hospital financial data, give a quick overview of data sources, and then talk about using audited financial statements themselves. So why should analysts and policymakers look to understand hospital spending? It probably won't surprise you to hear that hospital spending is nearly half of all healthcare spending, and that's inpatient and outpatient facility spending only, not including professional services delivered in hospital settings. Hospital spending is also growing quickly. Since the early 2000s, hospital per capita expenditures have grown much faster than inflation. And when we look at why hospital expenditures are increasing, it's like the classic health affairs paper states, it's the prices. Price growth is also the reason that per capita spending in the commercial market nationally grew so dramatically between 2017 and 2022. So why have hospital prices and therefore hospital expenditures grown so much and so quickly? This image here depicts something hospitals in many states are saying, that states and commercial payers could not possibly think about putting downward pressure on hospital prices or overall hospital costs, and that hospitals are really vulnerable now and can't withstand financial challenges, economic downturns, and unanticipated expenses. And they're pointing to both recent events since COVID and longer-term challenges to make that case. And I'm popping just a few of those on the screen now, but they include aging plant, input costs, low government payment rates, and throughput challenges that result in longer length of stay. Looking at hospital financial data can help us understand the real story. First, how have hospitals recovered from COVID-era challenges? Second, how does hospital financial health vary across hospitals and systems? Where are there have and have-nots? Third, how have hospital input costs changed, and do they represent inflation or other external pressures or inefficient operating structures? And last, how would state affordability strategies targeting hospital costs and prices impact the financial health of hospitals themselves? To answer these questions, there are a few data sources we can look to. I'm going to focus my remarks today on audited financial statements, which are considered the gold standard in terms of data quality, but also come with some analytic challenges. But I also want to mention Medicare cost reports and IRS 990s. Medicare cost reports are available for all Medicare participating hospitals. There are some significant weaknesses, including data quality and usability, but sometimes it really just is the best data available for a particular task. The NAHDO Hospital Cost Tool deserves a shout out. It's an amazing resource to access some key fields here, but for analysts who want to dig in further, combining files from Medicare's Healthcare Provider Cost Reporting Information System, HCRIS or HCRIS, through SaaS or other software is needed. For 990s, these collect information on tax-exempt organizations. The data included in 990s isn't comparable to audited financials or Medicare cost reports, but it does include some helpful information, unique fields on things like community benefit spending. So now we're going to move forward focused on audited financials. Like any data source, audited financials have strengths and weaknesses. On the plus side, they're the most detailed health system financial reporting available. They're available reasonably quickly, usually within 3 to 6 months, and use standard accounting principles. They include detailed footnotes that are very rich with information. And reporting at the health system level is generally a positive, includes all holdings of a parent organization. So rather than looking at a specific hospital individually, you can really look at it in context of its parent entity. On the downside, audited financial statements are not necessarily available for every hospital in every state, and in particular, for-profits and especially private equity-owned hospitals are less likely to release these publicly, and where they do, often include limited detail. They also need to be manually standardized, and we're going to get to this a little bit later, but this can be a very significant effort and requires some special expertise. They don't always include facility characteristics since they're often at the health system level, so you might need to incorporate data from other sources. And they may be more consolidated than you'd prefer for some uses. So for example, where an integrated network includes insurance companies and hospitals, or a hospital or a health system owns insurers, your staffing expenses might include staffing for both of those subsidiaries. When analyzing audited financials, I recommend looking at 8 key measures across 4 categories, which I've listed here. The measures that I suggest are all fairly standard measures of hospital financial health, and we describe them quite fully in the Guide to Understanding Hospital Spending Through Financial Analysis, which is a publication I co-authored last year that was released through the Peterson-Milbank Program for Sustainable Healthcare Costs. By looking comprehensively across all 4 categories and across multiple years of data, we can get a thorough understanding of how hospitals are doing financially. So now I'll walk through each of those 8 key indicators. The first category is profitability. So is the hospital or system making money on core operating activities, like patient care, and on their entire business, so including non-operating activities like investments. The next category, liquidity, is about how much cash hospitals have and how efficiently they're collecting on bills made to patients and insurers. So I'll flag this as a place where it's really important to look at the health system level, since hospitals that keep liquid assets at a parent health system rather than the hospital itself could look very cash poor when in fact they're very comfortable. The third category is debt capacity and solvency, which tells us how easily the hospital can pay its debt and whether they hold too much debt compared to their assets. And finally, capital investment measures help us understand whether the hospital or system is investing in itself so that its plant and its equipment are current and well-maintained. To really dig into each measure and get some help calculating them, I've included a link here to the Guide to Understanding Hospital Spending Through Financial Analysis. This includes an Excel-based template for standardizing audited financials so that you can calculate each of these metrics across a cohort of hospitals or systems or across multiple years and get comparable results. And to me, this is the most helpful part of the tool. The spreadsheet includes detailed instructions for use, including adding raw data tables to the template and standardizing audited financials using the categories we've provided to produce the key indicators we showed on the prior slide. As you go forth and think about incorporating hospital financial analysis into your work, I want to highlight a few rules of thumb for undertaking this kind of work. The first is to look across multiple years of data, ideally 3 to 5 years. So hospitals or health systems might have a lot of profit in some years and might lose money in others. So looking across multiple years at a time helps us think about the longer trend and trajectory. The second is that analysts need to look comprehensively across measures and measure categories. So for example, a hospital could lose money on operations for a few years in a row, but if they have healthy cash and not too much debt, this might not be a major concern. And finally, analysts and states need to remember your policy goals. So ideal or optimal hospital financial performance, like super high profits, tons of cash and reserves, and super new plant, might not serve your state's overall goals. I hope that this provided some helpful information to you and your teams to think about how to use hospital financial analysis and these key data sources in your work. I want to throw a huge thanks to the team at NAHDO and to KeriAnn for organizing this session, and I look forward to your questions.
Great, thank you, Sarah. Great presentation. I find hospital financial audits extremely intimidating, so respect. So let's see. As we're waiting for folks to ask some questions, I have a few teed up for you. I was wondering, where do you get the financial statements and kind of what's their format?
Yeah, thanks, KeriAnn. Can you hear me well?
Yep.
Thanks. So there are a couple of different places that you can potentially access hospital audited financial statements. My first stop is always a system called EMA, and I wish I could remember what that acronym stood for, which is for nonprofit hospitals. It's a place where lots of information related to hospital bond issuance and bond kind of reporting gets filed. So it's a great place to check, and you can kind of, there are great instructions in the Guide to Understanding Hospital Financials on how to actually log into those websites, find the statements that you need. They can also sometimes be posted in other places. So when I can't find what I'm looking for on EMA, which is for nonprofits, or EDGAR, which is for for-profits, sometimes I, find what I need just by like deep Googling or otherwise kind of digging through what else is available on the internet. But those are really good places to look. And I would add to that that credit rating websites, the major credit rating agencies like Fitch and Moody's, they're not going to be posting the audited financials themselves, but they can. They will often post rating commentaries for independently rated hospitals, and you can kind of learn a lot and get some help interpreting the audited financials by reading those rating commentaries.
Cool. So it sounds like a little bit of a treasure hunt for you.
That's a
and then what's the format of them? Are they in like PDFs or?
They're in PDF. So I would say the biggest challenge in understanding and analyzing hospital audited financials really is getting them from a PDF format into an analyzable format. So usually that involves manually extracting the data, the key kind of data tables in the audited financials into Excel. And the template that I mentioned in my presentation, which we provide with the guide linked in the chat, has some kind of spaces for you to do that and instructions on how to do that. But that's a really super manual process, but it is necessary because then you've got to actually work through them and manually put them in a standardized format so that they're comparable across hospitals, comparable across years. So it's a really, really manual process and can be challenging to do, especially when you're talking about a large number of years or a large number of hospitals or health systems. So any ideas that this group has for how we can make that process a little less manual, I'm certainly would be excited to hear that.
Yeah, me too. I think I heard some of your former colleagues at GMCB talking about like using Python to extract data from them. So I don't know, it's more to do there maybe. But Charles has a neat question for you. If you could require one single new line item or metric on a hospital's public financial report, what would it be and why? And also others listening in, feel free to respond in the chat.
Thanks, Charles. That's a great question, and not one that I have totally thought about before. So excuse me while I think on my feet a little bit. I think right now, a lot of the work that I'm doing connected to, but outside of this work, has been thinking about how to identify really efficient hospitals or inefficient hospitals, and how to think about hospital non-clinical spending and administrative spending. So while audited financials often do include some super high level information, like just a percentage of their expenses that represent clinical expenses versus administrative expenses, I would love to see some more granular and standardized high quality reporting there to help us understand, what goes into a hospital's clinical expenses, and whether those are appropriate clinical expenses, whether they might be inflated, whether they need to be invested in more. So I think there's a lot of questions there that I wish that I could get more answers to from audited financials.
Yeah, and on the administrative side too, right? You want to know what's labor and what's executive compensation, and all that stuff is important too. So okay, that's helpful to know that there might be some uh, limitations. And it looks like Chris Kent just put a link to Emma in the chat to see if that's the correct link that you use.
That's the one.
Awesome.
Thanks, Chris.
So now that's there for everybody in the chat. So thank you, Chris. Allison Ball has a question. What is the intended audience for this kind of reporting? And what are some next steps that the reporting can inform to improve efficiency and cost? Great question.
That is a great question. Thank you, Allison. So I really think it depends on what you do with this information. I think, states or entities could use this to shine a spotlight on hospital costs, to say, here are some areas where we think hospitals' costs might be really high. Or on the other side, here are some areas where here's some hospitals that are really super doing well and can shoulder the burden of kind of, affordability policies that would seek to reduce some of their profits or some of their margin in service of decreasing costs for consumers in the system. So I think it really depends on what you do with it. It can be used in really kind of micro ways to look at, just age of plant, how old's the infrastructure in our hospital system in XYZ state. But it can also be used to compare across hospitals and say, okay, are there some that are doing really, really well? And are there some that are really, really struggling? And do we need to take different approaches?
Thanks, Sarah. We got another question from Monica. Just recently reviewed the hospital financial analysis. Thank you. Very helpful, especially case studies and tools. In light of hospital closures, can this data be used to increase access if hospitals are not financially doing well?
Yeah, thank you, Monica. That is absolutely a major use case here. So I just released a different report that really looks at, okay, so we know that not all hospitals are the same, and we know that the financial status of hospitals is not the same. But what we see when we look at the data, and we look, kind of even looking back at the data, is that there really are some that are haves, that are really wealthy, that have a ton of reserves and a lot of market power, and usually high prices and high volume. And there are others that look like have-nots. They have way lower resources, way fewer reserves, and they might really be struggling or even at risk of closure or at risk of cutting services. And so I recently put out a paper through Peterson Milbank talking about how we can use these metrics and others as tools to really identify those hospitals that truly are struggling. When I think there tend to be industry talking points saying they're all struggling. No hospital can shoulder these burdens, and I don't think data really backs that up. It looks like KeriAnn maybe had a little bit of a tech glitch. Obviously, I could
I
talk
think
about.
I'm back.
Oh, there
Can you guys hear me? Sorry
Yes.
about that. I think we're ready to move into the next presentation, right, Charles? So thank you, Sarah, and we'll talk to you again at the end of the session.
Thank you all.
Hi everyone, my name is Alicia Duran. I'm a manager at the Massachusetts Health Policy Commission, which is an independent state agency with the goal of making healthcare more affordable in the Commonwealth.
My name is Alyssa Evans. I'm a senior data scientist at Mathematica, where we strive to improve public well-being through objective, high-quality research.
In this how-to session, we'll be discussing how to develop market baskets and payment indices. The underlying motivation for market basket development comes from the need to understand cost drivers, especially as states wrestle with increasing healthcare spending. Hospital outpatient services have been identified as a cost driver, but the vastness of outpatient services makes these services difficult to evaluate. A market basket is a tool that allows researchers to compare prices, especially of numerous individual service prices. So what are market baskets? A market basket is a common way to compare numerous individual prices across entities or time. In this hypothetical example of a market basket index comparing prices of two grocery stores, we can see the defining elements of a market basket index. Between store A and store B, the items and the quantity of the items evaluated do not change. These two elements would not change if we evaluated across time either. The only element that differs between both stores is the unit price of each item, which is store specific. The final payment index is the sum of the average price of each item times its quantity, which we can use to evaluate relative prices between stores or other entities. For store A, the final cost of the market basket of goods was $25.40, which was 14% more expensive than store B. This formula here represents the calculation of the final payment index, which again is the aggregate sum of the average price of each item in the basket multiplied by its quantity for every entity represented by J, where, for example, we can calculate the index for individual hospitals or grocery stores. The payment index would be comparable across entities or time because the items in the basket and the quantities of each item are fixed across entities and time. Alyssa will go over how to overview the market basket development.
There are many decisions you'll have to make prior to the start of your analyses. I'm not going to run through all these with you today, but a few questions you might need to ask yourself are: how many years of data do you want to include? Do you want to focus on a broad range or a narrow range of services? What will the minimum threshold of claims be for inclusion of a particular code in the market basket? Now I'm going to try to bring everything together that we've discussed so far with a set of steps that describe at a high level how to carry out a hospital market basket analysis. First, you'll decide on your design criteria that I was just mentioning. Second, you'll create a claims analytic file. Third, you'll get your data down to the hospital year and code level. You'll decide which codes qualify for analysis. And then thinking back to the formula that Alicia just presented, for each code, you'll have an average price, you'll have a fixed quantity, you'll multiply them together to get an adjusted spending. And for each market basket, the payment index is calculated by summing up the spending values for all the codes in the basket.
So now I'll go over an example that we implemented at the HPC. So the HPC sought to measure outpatient service prices across hospitals as they are a driver of spending in Massachusetts. To that end, the HPC developed a fixed quantity market basket of hospital outpatient department services using commercial claims from the Center for Health Information and Analysis all-payer claims database. The HPC selected the services and the service quantities for the basket based on commercial claims from 7 large insurers in Massachusetts. To select the services in the market basket, the HPC started with an analytic file of HOPD services delivered in 2023 at the procedure code encounter level, which includes professional and facility spending. Our minimum volume threshold was 20 encounters, so we limited our observations to encounters where a hospital had at least 20 encounters for any individual procedure code in the year. We then collapsed this file to the procedure code level to get a count of unique hospitals with sufficient volume. Of these codes, we retained codes where at least 50 out of 60 acute care hospitals in Massachusetts had sufficient volume. For the final basket, we retained the top 50 codes with the highest statewide spending. The fixed quantity of each code was defined as the statewide utilization rate for 100 commercially insured members observed in the APCD. For hospitals that did not have sufficient volume, we imputed prices based on hospital-specific price ratios. We took a simple average of a hospital's price divided by the statewide price for all non-missing procedure codes for that hospital. We then multiplied the average ratio by the statewide price for a procedure code in the basket that was missing for that hospital. If 20 imputations were required for a single hospital, we did not consider that hospital in the final comparison. The final market basket represented 18% of HOPD spending and 35% of HOPD volume in Massachusetts in 2023. This table lists the first 10 services in the final market basket, which contained various codes for endoscopies and colonoscopies, labs, and imaging procedures, among other services. And the statewide cost of the basket for the final payment index at the state level was over $32,000 per 100 commercially insured members in 2023. This figure represents the sum of the statewide average price times the statewide utilization rate for each of the 50 codes in the basket. The payment index using the same 50-item basket can also be calculated at the hospital level using hospital-specific average prices, which is represented in this graph. This allowed us to compare prices across hospitals in Massachusetts, which revealed that prices varied over 2.5 times between the highest cost hospital and the lowest cost hospital in the state for the same set of services. This finding can help guide policy for cost containment purposes. Finally, we've adapted the original methods to create a market basket of lab services, where we also evaluated patient cost sharing and benchmarked the index to Medicare rates using Medicare fee schedules. You can explore that work in previous cost trends reports. I'll now turn it back over to Alyssa for her example.
Next, I'll be sharing with you how we implemented the market basket technology at Mathematica. And before I jump in, I just want to acknowledge that this work was completed in collaboration with the Connecticut Office of Health Strategy, Peterson Milbank Program for Sustainable Healthcare Costs, Baillit Health, and other colleagues of mine at Mathematica. Our analytic file was built on the Connecticut All-Payer Claims database. We used commercial claims and enrollment data for calendar years 2018 through 2022. We limited it to outpatient facility claims at a hospital place of setting, and we made some exclusions such as denied claims and claims with negative payments. To create our market baskets, we mapped procedure code on the claim line to market basket categories based on a crosswalk developed by Freeman Healthcare. This left us with 9 market basket categories, including emergency room, outpatient surgery, and radiology. Our goal with this market basket work was to cover as much hospital spending as possible. Outlined in this table, I have the decisions we made for our first 2 rounds of market basket analyses. In both rounds, we used 5 years of data. Aligned with our goals, we used all services, which then mapped to the 9 market baskets that I just mentioned. We require there to be 5 claim lines for the code to qualify for our market basket. Next, I'd like to draw your attention to the bolded lines, which highlight the differences. In round 1, we had 10 hospitals and the same services for all hospitals. This aligns with the examples you've heard so far about in this presentation. In round 2, we did something a little bit different, where we created hospital-specific market baskets and allowed there to be different services across the hospitals. To dive more deeply into these differences, I've outlined the pros and cons of each analysis. So again, in round 1, we had 10 hospitals. Every hospital had the same services in the market basket, and we could directly compare hospitals to one another. However, we could only capture a limited number of services in hospitals. As you know, not all hospitals have the same services. So by restricting our analysis to services offered in all hospitals, we were missing out on a lot of services and spending. That led us to the second iteration, where we included all hospitals, and each hospital had different services in the market basket. This allowed us to better achieve our goal. We were able to capture much more hospital spending. Although we couldn't directly compare hospitals to one another, that was okay with us, and we focused on comparing a hospital to itself over time. This table contains the results of how much spending we were able to capture by market basket across the 2 rounds. You'll see in round 1, we captured anywhere from 2% to 90% of spending across the market baskets. In round 2, here I have the median percentage of spending captured across the 27 hospitals, which you can see was often 90% and above. To wrap up, I'd just like to mention some extensions that we've since completed. We've used 2 years of data rather than 5. We've used DRG codes to create market baskets based on inpatient stays, and we analyzed market baskets by payer. One extension we like to do in the future is explore the effect of our minimum threshold and the accuracy of the average price. In closing, we've included our contact information. And now I'd like to open it up to the audience for questions.
Great, thank you. Really interesting presentation. I know we're working on, Richard, getting the HPC market basket analysis in the chat for you, so that'll be coming soon. And please feel free to add some other questions in the chat while we're waiting. I have a question for you, Alicia, about the market baskets. Kind of how did you, Alyssa talked about a Friedman Healthcare crosswalk that maps CPT codes to categories, which became our market baskets like laboratory. How did you map codes into market baskets?
Sure. So in HPC methodology, we decided to do a broad range of services specifically that were primarily delivered in HOPD settings. So instead of mapping CPT codes to service categories, we limited our claims to all procedure codes that occurred in a hospital outpatient department setting. And we did that by subsetting based on bill type on facility claims and place of service codes on professional claims. From there, we did the methodology that I described in the presentation, but we decided to do this to get a broad range of services that were most often delivered in HOPD services rather than specific market baskets. In some other work that we've done, we do map procedure codes to specific service categories, and we've used the restructured betas classification system to do that before. But in this example, we decided to just do services that tended to be delivered in HOPD settings.
Gotcha. And just to follow up on the BETOS, I just want to flag that Friedman's crosswalk kind of maps those BETOS categories to some broader, like more intuitive categories from HCCI. So just kind of a shout out to them. And then it looks like Nate Polly has a question. Are there any unique challenges associated with developing inpatient versus outpatient market baskets?
Yeah, thanks, Nate. So the inpatient market baskets were actually a lot more challenging. So like I mentioned, we used the DRG codes, and there's just a lot fewer inpatient stays than there were outpatient claims. And when you're trying to create the market basket, you need, the same DRGs offered across hospitals or across time. And just because there weren't as many DRGs, it was hard to kind of get the quantity you needed to be the same across time.
Thanks, Alyssa. Is there like a specific cost driver that you found in this market basket analysis that either seems to be driving spending where prices are going up, or just a place where you've wanted to dig in a little further? It looks like Charles kind of just put that in the chat. So.
Yeah. Oh, sorry, that was for everyone, not for me.
You can answer, Alyssa.
I was just going to say that I feel like you always want to dig more. So we have found that this work was nice to give you a summary, right? So you know what is happening at a market basket level. But now that we were running to try to tell a story using our data, we're finding that we really want to kind of dig into a specific market basket and look at the services being offered there and kind of see what's happening more at a service level.
At the HPC, we were able to identify high-cost providers as well as payers that were paying the most for the market basket. Like Alyssa said, this is just kind of like a snapshot. It's not all spending. It's a small subset of spending in a category. But we've been able to year over year kind of monitor growth in prices, especially in outpatient settings. And that's something that our purpose for developing the HOPD index it's very useful for that.
Great, thank you both. If there are no more questions specific to Market Basket, I think we can open it now for the whole group. Okay, hi everybody. Thank you so much for your very informative presentations. While people plop some questions into the chat, here's some more things I could ask. Sarah, I think I wanted to hear from you more about like some of the measures that you're getting off the audit financial statements. Like, is there a sort of reasonably simple one that you can walk us through which fields you use and what you do with the measure?
Yeah, absolutely, KeriAnn. Thank you. So the one that I would like to focus on is days cash on hand. I think that's a particularly important measure, in part because days cash on hand really is a representation of hospitals' reserves and their ability to be financially flexible and to make it through tough times. And so when we're trying to calculate days cash on hand, we are trying to look at all of the sources of unrestricted cash and investments and other reserves. And that includes things like board designated assets. And you'll see if you start reviewing hospital audited financials that can come up in a whole bunch of different ways. So we've included on our template examples of kind of the wording where you might see that mentioned on hospital audited financials, and you know how to bucket it into board designated assets, which might be things like assets that have been kind of flagged or earmarked for a particular capital project or a big investment by the organization's board, but really they can reallocate those funds to something else if they need to. So when we're looking at days cash on hand, we're gathering all of those unrestricted cash investments, board designated assets, and we're dividing it by average daily operating expenses. So the organization's operating expenses for the full year divided by 365. And that will give us an answer in days. So for a hospital that's really comfortable, that might show us, 200 days cash on hand, which means that if they didn't take in any more money, they could continue to operate as they are for another 200 days, which is a pretty long time. For a hospital that's struggling, you might see a value under 100 or under 75. I will note, kind of asterisk there, for-profit hospitals tend to operate with very little cash on hand. So you might just see a couple days cash on hand when you're looking at a for-profit hospital or system. Oh, thanks, KeriAnn.
Yeah, that's helpful and really interesting. And I do have a question for you, Sarah, that I'm sorry in advance if it's a hot potato, but I was just intrigued by the missing private equity and some for-profit hospitals. And that seems like kind of, folks we might want to look at when we're considering haves and have-nots. So can you speak a little bit to kind of that absence and what it means for you?
Yeah, absolutely. So I would say most for-profit hospitals you can find audited financials for. Private equity really are the challenging ones. So hospitals that don't need to take on debt or hospitals that kind of are internally financed, I guess, are the ones that are particularly challenging to find audited financials for. And sometimes you'll find audited financials and they'll just be really they will not provide a lot of valuable information. And that is a real challenge. I will say, to me, this is a great argument for states collecting standardized audited financial type data from their hospitals. I think that can be, there are quite a few states that do this. Connecticut is one of them. Speaking of Connecticut, Massachusetts does the same. Maine does the same, California. So there are quite a few states that do this. And I do think it can be a really good investment in bringing in that information in a standardized way and requiring even, hospitals that don't have to seek out funding from the bond market to kind of put this information into the public domain.
Great, thank you. Thanks, Sarah. Asmita, I have a few more questions for you about the hospital transparency files while we wait to see if others have questions. Do you feel like are there ever files that you just have to reject because the data quality is so poor?
Yeah. So yes. We have come across a few files that we had to reject. For example, this year there was one hospital file that was unstable or corrupted, if you may, and we couldn't decode that file properly. So yeah, in such cases, we typically document what the issue is, and we share that with our clients so that they are aware of the data quality problem and they can reach out to the hospital if needed. So yeah, generally speaking, if we reject the files if they can be decoded properly or if they appear corrupted, incomplete or non-compliant with the CMS regulation. For example, if peer names are missing, if the file format does not match the standard with what CMS has regulated, we flag those for review and we reject those files from adding to the report.
Great, thank you. And it's good to know there's a little bit of a feedback loop back to the hospitals when they have poor quality. Monica has a question for each of you. What's next for these data sets for each of these teams? I heard interest in deeper diving into the data. What kind of questions are coming up? So maybe we can start with Alyssa and Alicia on that one.
Sure, I can give our perspective at the HPC. I know, especially kind of keeping with the market basket theme, one of the limitations that we faced was that we didn't want to include in the basket things with low volume, but oftentimes the low volume things also tend to be very expensive. And so for us, that was administered drugs. And so something that we want to continue looking into is administered drugs as a spending driver, potentially making its own kind of market basket. But again, there's challenges with volume there. But that is something that's kind of coming out of what we did here with the market basket index.
Great, thanks. Go ahead, Alyssa.
Yeah, so for us, I think there are two things. One is, so I mentioned we kind of switched from 5 years to 2 years, and that was so we could capture even more services in our baskets. And so we'll be updating that with the next rolling set of 2 years of data. And another thing that we have a lot of interest in is kind of service mix. So are people using the more expensive services or the lower cost services, and kind of how are they interplaying together?
Yeah, and Alyssa, if you don't mind me adding to that, just since I've been a little involved in that work too. I mean, I think that's been such an important question for us, is really trying to disentangle whether spending is going up because of a shift to more expensive services or like a sicker population, or if it's just straight up price growth, right? So that's what we're trying to figure out with market baskets. And we do find evidence of service mix shifts, especially in some of these, bigger hospitals. So yeah, I think that's really been something we've been looking at a lot. Sarah, do you want to answer the questions in terms of what's next for the audited financial statements? Some deep dives you might like to do?
Yeah, thank you. I mean, I think just more opportunities to look across hospitals, across states to help us understand who are the haves, who are the have-nots, and what do they look like, and how can we use that information to support policymakers in being able to kind of target their affordability work. I think that's one place. And as I said earlier, I think thinking about how we can use this information to further study administrative spending and hospital efficiency is one where I'd love to be able to dig in further.
Thank you. And Asmita, how about you? What's next for your data sets?
Yeah, so we can see there is a lot of interest in the data set at the reporting database that we built after combining 85 hospital files across different hospitals in Colorado. We do all the cleanup, build this huge reporting database, but we have not done a lot of analysis into it, looking into the data or combining or linking this data with other data sources and do comparing between those two data sources. So for us, I think our next phase or next step would be to link this price transparency files with other data sources like APCD to analyze price alignment variations and see the discrepancies between those two data sources.
Yeah, that sounds really interesting, and I wanted to ask you about that. And sorry if it's a premature question, but have you kind of looked into that at all? Like, do you have any sense of kind of what variables you would use to link the data sources and kind of what that might look like?
Yeah, absolutely. And that's a great question, KeriAnn. So yeah, we have done that in the past. So we actually link the price transparency files with the APCD database. So I mean, like, it's kind of tricky when you try to link those different data sources, and like, you can imagine how messy the hospital's data could be. So that did require a lot of standardizations and identifying what fields you can match or link those data on. So we did that once in the past. So when we did link, so we tried to link the hospital files with APCD on 3 different fields. So one being the hospital name or the hospital NPI itself. So we try to find the hospital names from those data files to the hospital names that we have in the APCD. And the other, and the second field is being the procedure code itself. So whether it is CPT code or DRG code. So we match on hospital name, the CPT or MSDRG code, and also we did the analysis at peer level. So we also try to match the data on at peer level. So those are the 3 fields we use to link up those 2 sources.
That makes a lot of sense, and I imagine it's a bit manual sometimes trying to clean the text fields so they match.
Yeah.
So, but that does sound like a really rich place to do some additional analyses. Great. Well, I don't see any more questions in the chat. Any final, maybe I'll give you each just a moment to give us some final thoughts about your data set. So sorry to put you on the spot here, but Sarah, I'm going to start with you.
Sure. I think audited financials are such a rich data source. I think there's so much that we can learn and that we can use from this data source in terms of helping policymakers understand, what's really going on with hospitals. How is it the same as or different from what we're hearing in the news, or different or the same as what we're hearing from, hospital lobbying organizations or hospitals themselves. And I think that can just inject some kind of data-driven truth into the conversation about, okay, so where do we go from here in terms of supporting affordability of healthcare services generally and of hospital care in particular.
Great, thank you, Sarah. Asmita, do you want to give us some final thoughts on the transparency files?
Yeah, just going based off what Sarah said, the transparency file itself does not, I think it's not, enough to provide the information to the consumer itself. Like I've shared in the presentation, the files are messy. Some of the information is, the information is incorrect or incomplete. So using that transparency files in addition with other, data sources or data files will provide information that, so that consumer can make informed decision whether, where they, want to get the service, or, they can compare the price across facilities, or they can find the price before actually receiving the care. So yeah, using this information in combination with other different data sources will provide complete pictures on what the healthcare cost or care looks like. So yeah, I think this source or transparency file will be really helpful if they are used in combination with other different data sources to make that informed healthcare decision for consumers.
Great, thank you. So maybe one of these interactive consumer-facing price tools.
Exactly.
Great, thank you. And then Alyssa and Alicia, any final thoughts about the market basket method you want to share?
Yeah, I just want to really emphasize how helpful that the payment index has been. So previously, we had this measure called payment per unit, which we still do use, where it's total spending divided by total quantity. And we would calculate the percent change, and it can be hard to disentangle why that measure is going up or down. Is it because spending is increasing, or is it because the quantity is decreasing? So by using the payment index and holding quantity fixed, it really allows us to zone in on the price change and how that's impacting the overall hospital spending situation.
Yeah,
I'd agree
thanks
with
for that.
Alyssa. Yeah.
Go ahead.
Just to add that I think the market basket index is a really good comparison tool, like Alyssa mentioned. It's useful to be able to compare prices year over year and across providers because it's standardized and it has those fixed quantities is the basis of the methodology. So I'd say it's a really useful tool for states to use if they're seeking to examine prices.
Great, thank you so much. And I think that concludes our session. Hey, Charles.
Yeah, hi, KeriAnn. Thank you. Thank you to the organizers, moderator, and all of our presenters, everyone for attending, and a special thanks to the session sponsor, Mathematica. Let me just mention really quickly that next up is breakout sessions. There are 2 of them, points of view, thoughts on emerging federal issues, and state showcase. I thought that that was the end, so that doesn't actually feel quite right to me. The other is, yeah, points of view and driving healthcare value, examining patient safety, prices, and scarcity. Hope you all enjoy the rest of the conference. Have a nice day.